As usual, it is my esteemed pleasure to welcome a special guest to my space this evening. And I do not have enough words to speak to the caliber of this woman who is with me today. She continues to do tremendous work that you will be hearing about. I am not sure that we can even talk about all of the things that she does, but everyone knows who's been watching me for a while that it's always my desire to bring to this space someone who will challenge us by the work that they do. And I do that in the hope that by listening to these people and watching all of these guests, we'll also be challenged to think about the things that we can do to continue to make our world a better place. My guest today is Dawn Wilkin, who is a New York State credentialed prevention specialist. And she has been doing that. She's been doing that for over 24 years. And she provides training, technical assistance throughout the Mid-Hudson region of New York State. And she's currently the Director of Prevention Services for Catholic Charities of Orange, Sullivan, and Ulster Counties in New York, overseeing substance use prevention programs and services in those counties, including providing direct oversight to one community coalition. She is just completely amazing. From the first day that I met Dawn Wilkin, I actually have been impressed, and it's been several years now. And she really is great at strategic planning, which is one of the things that she does throughout these counties. And she has done a lot of work in the tobacco area also. And it's my hope that today we'll be hearing all about it. And she was part of the planning team for the Hudson Valley Interlink Analytic system and the PeerRX, and serves on multiple county and state committees to promote health and safety, diversity, equity, and inclusion for the communities she serves while advocating for their needs. Dawn, welcome.
Thank you.
I am going to start from where we stopped, before we began to trust.
Okay.
I asked you, with all of these things that you do across New York State and to continue to grow your program, do you rest?
Sometimes. Sometimes. I rest on the weekends when I can. Sometimes there's evening work, sometimes there's weekend work. So we try to be flexible with the hours, not just for myself, but for the entire team in the counties we serve, in the different counties. Because within this field, and particularly with my staff, there's a passion. We know we're not coming, it's nonprofit. Nobody's going to get rich. You're not in the field for anything like that. You're in there to serve. And that's how we see ourselves as human servants through the lens of substance use prevention, which we'll tease out a little bit more what that looks like.
Right. So who is a credentialed prevention specialist?
So
how does a person become one?
Yes, that is through the Office of Addiction Services and Supports. I had to write that down because the acronym is New York State OASAS, and I always get it wrong. So I made sure I wrote that down. And so that OASAS, what they've done is they've provided pathways for people through different stages of the substance use field. So you have prevention, intervention, treatment, recovery, and it all kind of comes back around. So prevention's like the first little ring on the ladder, right? You're stepping on that. So to become a certified prevention specialist means that you have met the state standards to come in and be a qualified healthcare professional under OASAS within that field. So there's two different, there's the prevention credentialed prevention specialist and then the credentialed prevention professional. So there's two different ones. I'm a CPS. For both, you have to be 18, at least 18, and you have to live in New York or work in New York at least 51% of the time. Those are the two baseline credentials. For a CPS, you have to minimally have a high school diploma or high school equivalency. And then for CPP, it would be a bachelor's. And OASAS did a good job with their credentialing system to allow people who've had lived experience with the substance use world, but may not necessarily been able to take advantage of educational opportunities for whatever those reasons may be. So it allowed them to come in and to help. So you have to have 2,000 supervised work hours for a CPS, 4,000 for a CPP. Your training and education for a CPS is 120 versus 250 for the CPP. You go through all of that. There are certain trainings that are required, like ethics, cultural competency. Now they're requiring cannabis, the science of cannabis, because in New York State, we have legal, recreational, and medical. So we have to understand that. Again, cultural competency. You fill out the application, you take the exam, you pass the background check, and then you pay the fee, and you can then get your credential. And then every 3 years, you are required to show an additional 60 hours of new education to maintain that credential. So that's the process in New York State to do that. If you are like in school, you could be associates, a bachelor's or a master's, you can use some of your education if you're in the human service field towards your education hours. So it's not like you would have to take additional on top of your college courses. A lot of people who already have that education use those hours to get in to satisfy that need. It's the supervised work hours that tend to be a little bit more difficult to find.
It has just come to my attention that one of your colleagues in the field, Regina Sislak, is watching.
Hi, Regina.
Right.
Oh, Regina was my my go-to. She was like we were together. We were in the car. We would joke. We were Thelma and Louise for prevention, and we would go.
Right. So let's try and clarify something, because I
Sure.
know there are some people watching us from other countries. And so when we are talking about prevention right here, we're actually talking about substance use prevention, right?
Yes. Yep.
And so what might be the substances that people tend to use the most?
I think that depends on where you are in your life. So most people, let's say the younger people, I'm gonna say kids, I'm dating myself, but younger kids, um, we would say alcohol, cannabis, tobacco, vaping now is huge, whether it be cannabis or tobacco. Those tend to be like your quote unquote gateways. That's where you're going to see more use with that. You'll see the evolution of use as people age. And then you'll start to see more, maybe some cocaine. It used to be club drugs. You still hear about them. They're not as popular as they used to be. And then, of course, we're dealing with the opioid crisis right now. So we're still dealing with that. And so then you would have moved into more pain medication, heroin, which you really can't even get heroin on the street anymore. It's all fentanyl and a new drug called ISO. It's
Mm.
not new, but it's new to the streets, and it's another strong opioid like fentanyl that
I'd
they
like
see.
us to spend some time talking about opioids
Mhm.
very soon. But when you were answering the first question, you talked about legal, recreational, and
Mhm.
medical uses
Mhm.
of these drugs. But I don't think that you were saying that there is medical use of cocaine, for example.
Correct. It's just cannabis. Just cannabis.
Cannabis.
That's it.
Right. And so, what is your job as a director of prevention services consist of?
Um, it varies. To me, sometimes it's a lot of, I feel like if you think of the cartoons where they would glue a vase back together and then they would fill it with water and a crack would come and you put your finger and then another crack and you put your finger over here. I feel like there's a lot of that happens. Um, so I oversee a staff. Right now we're 7. I have a few grants out there to get some more staff members to grow the program. Um, so we have a staff of 7. So the day to day with that making sure everybody's on track with that. I write the grants that we go for. I write the state work plans that are required every year. I call it like our static state funding. This is what the Office of Addiction gives us annually. And right now we're in Orange and Sullivan counties doing the prevention work, looking to expand more into Ulster, just providing some technical assistance. So that static money is there. So they get work plans every year. And then every year you have to write an annual report based upon the programs that you've done. What have your outcomes been? Any questions by the state or any other local, state, or federal funder comes through me, and then I address that. I make sure that staff are doing their strategic plans that are based upon the funding stream, logic models, evaluation. Are we doing our surveys? But my favorite part, I mean, that's I could do the admin part and I can do the background, and I'm glad I can. But my favorite part is literally being in the streets, talking with people, and making those connections for people. Like that's my favorite part. And so for me, taking the director position, that's been the hardest piece to let go of a little bit because I have to be more behind the scenes. But whenever I can, you'll see me in my hiking boots, walking around, talking to people, and going out with everybody from my staff to our partners on the different coalitions, and just trying to reach people and educate and trying to get them, what they need. And it doesn't have to be substance use prevention services, because when you think of substance use prevention, you immediately think of the drug itself. But it entails so much more. It's feeding people. It's making sure people have a safe place to eat. Are people getting education? Is there equitable opportunities in the community? What are the factors in the community that are supporting people to do better, or are actually having the adverse effect and are holding the community down? So those types of things, the community scans, just going out and seeing where people are hanging out, just going up and having the conversations. I mean, that is one thing I can say about our team. We will talk to anybody. We'll just, hey, how you doing? Um, so those are the big pieces, that I think get missed sometimes in substance use prevention. Those pieces are crucial to preventing substance use. To have steady food, to come from a family that is healthy, to have an outlet as a child, because usually with prevention, the younger the better, right? So we try to get in as
Mm.
soon as possible. Um, but those things are crucial for the child, because you can teach evidence-based programs about resiliency skills and how do you say no. It's not just say no. Well, what does that look like, and what are some techniques I could use, which is great. But if we're not in the community supporting as a community what is being taught, we really haven't done prevention. And that's when you have to rely on your partners on the different coalitions to come in and to assist with those pieces.
Right. When I was introducing you, I talked about how from the first day I met you, and
Hmm.
I think we both remember that first day that we met
I
several years
did.
ago, and you were giving this presentation. I was so impressed, and I knew that we were going to really get to know each other well in the field. And how have you kept that passion till now? Because it's something that, it doesn't take 2 minutes of watching you to for anyone to realize that you are really passionate about what you do and you care about the people that you work
Yeah, yeah. For me personally, I had my own issues with substance use as a child. So that kind of drove some of that. Never thought I'd ever be in this field. Didn't even know what substance use prevention was. Had no clue. That's a whole nother story. But so then as I got to learn, and you start to talk to the community. So one particular community we work in is always getting like a bad rap, always. And there's a lot of issues that go on in this city. Um, and but when you stop and you talk to the people and you hear what they're going through, and you hear them say, like, oh, we always take the bad rap for this. We really don't want it to be this way. We don't know what else we could do. And they become victims of the circumstances that they find themselves in, whether it's because they can't afford anything, that it's so expensive, right? So they can't afford to live outside of those city limits because it's just not feasibly possible. So they have to make that choice to stay. But then when you do that, you hear about this particular city on the news, and this is happening and that is happening. But then you talk to the people and you see how it affects them. How could you not want to help? How do you not help the child who says, Miss, every day I come home, the lights are off in my apartment building and people grab me out of the dark. How do you not want to help that child? How do you just walk away and say, well, okay, well, have a good night. See you next week. I don't that my brain doesn't work that way. So I think for me, I remember those who were there for me and helped me through my struggles, not just when I was a child, but my mentors now. I still give them all the credit. Uh, and I remember what that felt like. And I think that's something I conscientiously made sure I didn't forget when I entered this field, because I didn't want to lose sight of that, because I didn't want to become somebody that is just numb, and you're just like, yeah, okay, if we do, we do. If we don't, we don't. I don't ever want to become that person. You're talking about
Mhm.
people's lives and their livelihood. And so how do you not, if you hear this, how do you not act on it? So that's kind of, where that comes from for me. Just I'm hoping that I can be that for somebody as somebody helped me, and to pass it on. As one of my mentors said, it was never truly yours if you can't give it away. So
Yeah. So, have you found that it is actually possible to prevent substance misuse? If so, how come we haven't been able to do that as a society?
it is possible. I think we need to be realistic. There's always going to be substance use. I mean, that's just the reality. But I think we can really make a dent in it and really bring those numbers down. That requires, though, for us to be able to do that, that requires funding. That requires funding on a larger scale. There's always funding. We're a very reactive society in New York State, in America. We're very reactive. It's not a problem till it's a problem. Don't worry about it. But we talk about diabetes prevention, heart disease prevention, obesity prevention, but substance use prevention, oh, we can't talk about that. We don't want to talk about that. And I think that's the key. We got to talk about it, and it's okay to talk about it. It's okay to have these conversations with your children, because it does start at home. It's okay to have these conversations as human servant workers, to have these conversations with adults and with youth. I have seen youth turn their lives around. I have seen them decide not to take that step, because if you use before the age of 15, you're 4 times more likely to develop some type of addiction in your lifetime. That's why, delaying that onset of first use is so crucial, because you got to give that time for that prefrontal cortex to develop. And these programs that we do are designed to help develop that a little bit and get them thinking in ways they don't normally think, about consequences and decisions and goals. And what if something gets in the way of that? What would you do? Because you got a 13-year-old and they want to go to a school dance, and now all of a sudden something happened and they can't make it and the world has ended. You know what I mean? Like, it's all over, and well, how do we get around that? How do we prepare you for those things, those types of conversations? So I have seen it work. I have seen kids come through. They're city council members now, um, who have gone through the program. They're legislator, there's nurses, they're doctors, and you see them come through. And then sometimes you hear a story, and never forget, one of our partners said to me, I was sitting at a school board meeting, and I had started my work in Dutchess County in southern Dutchess, so Beacon and Wappingers. And there was a school board meeting, and one of the kids I had in through the years was speaking, and she decided she went to school to be a social worker. And she said the reason she did that was because when I would come in and have conversations, she actually took the time to take a step back and look at her life, to see the decisions that she was making and how it would affect her going forward. And it was because of those conversations, that somebody took a time to sit and have these conversations, that she decided to make a change, and she wanted to help others. And so that's what and tears. When I was told that, I'm like, stop it, don't do that. You're just trying to make me cry. I was like, come on. But it was true. And so you never know who you touch in this field and how you touch them. I mean, there was another young man, and gang involved. Um, we at one point at Catholic Charities were in a combined setting where there was adolescent treatment and prevention. Not He came in very angry. I won't repeat some of the things he said, got through it. Went out in the community doing some street outreach, going through the different neighborhoods, and there he is. And I'm going, oh boy, because it didn't end so well. I'm like, oh no. Um, and so now we're on his turf, right? And I'm going, oh no, this could be bad, but we're going in. So I'm looking at my ex-director, Martin, one of my mentors, and we walk in
Who I
and
also know, by the way.
yes, yes, Martin's amazing. And
Yes.
so we walk in and he goes up to Martin. He goes, "Hey, Mr. Martin, remember me?" And he goes, "Hey, yeah, how are you?" Because we never address somebody that's in our programs unless they come to us. We want to respect that privacy. And he said, "Yeah, how you doing? Da 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 da." He's like, "I'm good." And he looks at me, he goes, Miss. He goes, "You remember me?" I said, "Oh, yeah, I'll not forget you." and and he started laughing. He goes, "Are you good out here, Miss?" And I said, "Yeah, I'm okay." And he looked at all his boys and he said, "Listen, let them through. You are safe while you're in this neighborhood. Please go and help our neighbors." That to me spoke volumes about how this young man was touched. And it literally took Martin one day when he was had this young man was having a breakdown in our office and we had a little kitchen and he goes, looked at me, he goes, "Did you eat today? Are you hungry?" And he goes, "Yeah, I haven't eaten." He goes, "Come on, let me cook you some eggs. Let's go. Let's go talk." And that's what did something simple as cooking some eggs and giving the child something to eat. And that's what turned him completely around.
Right. There is something that I want to say before I ask the next question, which I think will be a natural flow from this. I will say that you really have no idea how many people you have impacted. And as you know, I am currently at a university where I'm developing a social work program from scratch, as you know. And one of the specializations that I decided to add to that program was mental health and substance use disorders. And as I
Yay.
was, yes, because it's very important. It's an affluent area, but as I was actually developing that part of it, I was thinking about you. And that's when I said I had to speak to you.
Oh, thank
The
you.
reason being that there are people who just will maybe just teach it as a course, or just do the work as therapists, but don't really have the experience and the passion, the understanding that you have of it, the relationship between substance use and the environment and the family, and in your case also the way you talk about it, the community. And all of those connections are important, which is why even as I think as we move into the process of hiring faculty, I am saying to myself, if I am going to have someone teach uh, in the substance use disorders section of that program, they need to be someone who really understands it beyond what we read in textbooks.
Oh, thank
And
you.
because of you and Regina, it was all of that work that I saw you do in real life. It is difficult to actually talk about it, but by the end of today, you are going to promise that one day you will speak to my students. And
I will. I'll come to Delaware. Regina's going to come with me too. We're going on a
yes,
road trip.
yes, the great University of Delaware will be very happy. We will be happy.
Oh, I would be honored. That would be fantastic.
Yes. And so I was hearing you talk about those young people that you had worked with in the past, and who talked about how you influenced them, and that one who sort of created a safe passage for you
Hmm.
in that community. And I was saying to myself, if what Don is saying is all true, and I know it all to be true, how is it that there is such um, stigma, as we know,
Hmm.
relating to substance use, and knowing that these are people just like us, everybody who gets addicted, it can be any of us, right?
Hmm.
So what I'd like you to do is to educate us about the stigma related to substance use and how we as a society can be better in dealing with substance use disorders and prevention without attaching that stigma to the
Right.
disorder, the
And
disease.
yeah, I think that that's hard. I think for some people, um, speaking in a way that's stigmatizing to someone who's struggling with addiction comes from misunderstanding and not really understanding how this works. That it is a brain disease, Yes, everybody has that choice when they pick up that first drink or that first drug when they're younger. But once that kicks in, it's not a choice anymore. And I think that's hard for people to grapple with who've never experienced that. So there's one piece. I think there's misunderstanding. So I think as a field, we're really trying to hone in on better education, really watching our language. Like even for marijuana, I've been saying cannabis, but that's because of all the racial implications that come in America with using the term marijuana and how it became known and all of that. So we now use the term cannabis in my office. Not all offices do across the state, but that's what we've chosen to do because of that. Understanding that, okay, let's leave that word alone. We'll go over here. We use it so that people understand that marijuana and cannabis are the same, but that's about as far as we go. Um, and I think there's that piece. I think it's hard for people when they see, for example, those on the streets who have nowhere to live and they're just like, oh, it's just some drug addict and they're a bum and this and that, and not understanding that that person has a family. That person has people they love. They have people who love them, who are also suffering because of the individual's struggle with addiction. So it's bigger than the person. So you're not just stigmatizing the person, you then stigmatize the family. And that kind of gets to me to this day because I don't know, and I can only speak about New York State and a lot of America probably feels the same. I don't know too many people who've not been touched at this point by addiction in their lives. So the fact that we're still dealing with stigmatizing language and we're stigmatizing people who are struggling just doesn't make sense to me because at the end of the day, I've been good for years, and I already mentioned I had my struggles with substances when I was younger. I am one decision away from going back. And despite all I've done, I keep that fresh in my mind. You could easily go back to where you were, And so for me, it's disheartening. I think language is important. I know, people have this back and forth about the language we use. I think if you're looking to help somebody, you want to use uplifting language. You don't want to demean somebody who's already down. I mean, how much further are you going to push them down? I just, for me, I don't understand. So education is huge, and we're trying to work on that. Understanding again, just like there will always be substance use, there will always be people who see it this way. The important piece is that we continue to educate because then we can have more people on the side of understanding than misunderstanding or just refusing to understand. And I think so. I think that that's important. I think the fact that it came out and they put substance use disorder in the DSM was a big move forward. I think all the information about it being a brain disease was a big move forward. But again, I think we get caught up in language sometimes in the field, and I call it a little bit of gobbledygook, and we need to bring it down to simpler terms. One thing in our field, we always say, keep it at a third grade reading level. Keep it at a third grade reading because you never know. Somebody could be very interested, but may not be able to read what you just put down, and so they just put it back. So we try to do that. We try to do things in other languages, and particularly Spanish. We have a high and a lot of the communities we serve, at least 50% are Hispanic Latino. So we definitely do that. But now we're finding Haitian. And thank God one of our workers, he's brushing up on his Haitian because we put him on the spot. He hadn't spoken in years, and we were at a presentation. We're like, oh, we need someone who can speak Haitian. You're going to learn how. And he was nervous, but he did it. And they were wonderful because they spoke with him and they helped him, but they understood what was happening, and it was really meaningful for my staff to do that as well afterwards. They were nervous at first. I was like, I haven't done this since I was a little kid. Like, you're good, you got this, don't worry about it. So
Right.
language is hugely important with stigma. There's a big focus in New York State on harm reduction right now in regards to the opioid epidemic, and there's a lot of stigma in particular around the opioid epidemic and those who are struggling with that addiction in particularly. So that's a big one, which again I find interesting as to how it started and how we got to where we are. That's still happening, but we continue to work on that as well. You have to when you're working with people and you're trying to get them into trying prevention, a piece of it is trying to refer people, trying to get them to the help that they need. So a piece of that is food, it's housing, but it is also the actual treatment of a substance use disorder. So to be able to sit and talk with somebody and just have that conversation, or to help the mother who just shows up, we're having an outdoor event, who says, my son is 17. He has an issue and I need to get him through. And she's in tears, So I walk her to the clinic and I say, hey, somebody needs to talk to her. She's got limited time. Her son is 17. She's got till he's 18 before, but then the intervention is really hard to do because then they're considered an adult and it's harder to do that type of intervention. So, fighting for those people because they don't know either, and it's hitting families who thought they would never experience substance use disorder in their families or with their children or their spouses, their loved ones, and it's happening. And so you would think stigmatizing language and all of that would be decreasing, but unfortunately it's not.
I will tell you that when I was in social work school many, many years ago, decades ago, um, I came out of social work school knowing that I did not want to work in your field. Yes, and but then years later, I began to wonder why I didn't want to do that.
Mm.
And then I began to say to myself, could it possibly be that perhaps, because when you do work, there is some sort of reflection on you, right? You
Mm-hmm.
get to begin to think more about yourself, about your life, your family, because of what's before you. And so I began to say to myself, could it possibly be that perhaps I did not want to find out
Mm-hmm.
that if my work became a mirror for me, uh, was it possible that I didn't want to find out that there were alcoholics in my family? There were
Mm.
people in my family who were addicted to some substance. And I say that because of the point that you made. You said you do not know, you know hardly anyone now who
Mm-hmm.
has not been touched by addiction. It could be a distant family member, it could be a parent, it could be a relative of some kind, but the reality is that if we all look closely enough, there is none of us whose family is not touched directly or indirectly by substance use,
Mm-hmm.
and even substance misuse. So that we definitely just lie to ourselves when we think about people who are addicted as those people.
Right. And why is that?
Why? Because
Yeah.
those people, yeah, we are those people. Those people are
Yeah.
us. And like you said, the first drink might be a choice, but beyond that,
Mm-hmm. If
especially
somebody's
for
got
one who
that.
is, yeah, especially for one who is predisposed genetically
Mm-hmm.
also,
Yeah,
you know,
absolutely.
yeah. So speak to us now about the opioid crisis that communities across our nation have been battling for several years now.
Mm-hmm.
And it's interesting because when I think of the opioid crisis, I think, and you can correct me on this, because the way it feels for me, is that the opioid crisis was already going on. And it just feels as if it was not until it began to touch the rich families that
Yes,
government actually decided that it was a problem
I
that
agree.
needed to be funded.
Mm-hmm. I agree. I mean, and that's one of the things that, I have said, to some people get a little taken back when I say it, but it hit the wealthier communities, primarily white communities. When it hit within those communities, it became a bigger issue.
Yeah.
When we had poorer urban and rural communities who could be primarily, African American, Black, Hispanic, Latino, who've been dealing with this for years. It never went away. It just became hidden because, well, it's over there. It's fine. It's not going to touch us here. So and that became, that's how people began to think, oh, it's over there, so that's fine. But one of the things we talk about, and particularly for, the one city that we're talking about, which is Newburgh, if it's happening in Newburgh's front yard, it's happening in your backyard. Don't be fooled, because I've watched people come in, affluent young people come in, they're not from the city, and I can sit and watch and I can see The deal happened. I can see him leave. And here comes another one. And here comes another one. So those with means and money are actually going to these communities that everybody were like, oh, it's their problem over there, and accessing. Okay, that's how it used to be. Then here comes the prescription pills. And it became, oh, well, it's a prescription. So it's okay. We're fine with this. And everyone was told that you will be fine. Don't worry about it. And that's when you really seen it take off in white middle class to upper middle class America. And it wasn't just all white, but it did really seem like once it hit that level of white middle class America, that's when people really started to take notice, right? The politicians and everybody else were like, oh, what is happening? Meanwhile, I'm looking at everybody over here going, they've been dealing with this for years. What are you talking about? This is not new. It's new to your community, but because it didn't hit your community and you're the policymakers, nothing was done to support these other communities. And now with social media and kids are purchasing different substances online. They're using social apps like TikTok and Snapchat, and they're using the little emojis, and the emojis mean different things when you're purchasing. Then they're using apps like Venmo and Cash App, which I don't understand why you would do this, but they do. And then they're purchasing and they're paying people this way. So it became a thing, especially during COVID. I mean, because, this is when this really took off and it's just continued. So we're more tied together socially now. I think back in like the 70s and 80s, there was more of a social separation. It was there, but it was really more separated. Then as we got more in tune with each other and being a part of each other's communities more, everyone started to blend. You add in the prescription drugs that came in, it became this powder cake. And to this day in the epidemic, which has been historically true, the primarily the population that's experiencing the most opioid overdoses continues to be white male Americans between late 20s to mid 30s. That's still your primary. That has not changed. It continues to be your primary population. Not that others aren't, but that's the population that's experiencing the most opioid overdose and death, unfortunately. Because it's just sad no matter who you are.
Right. How is this crisis, the opioid crisis, and the battle that we are waging against it as a society? How is that different from the battles that we fought against other drug addictions? For
Mm,
example, the crack epidemic.
right. The crack epidemic. Interestingly, the crack epidemic, I'm just going to use the word was contained into certain communities, and it never really came out of those communities. If you wanted to use, you went in, that's what you did. It never really came out into other areas. It kind of was really contained. And there's a lot behind that one. We could have a whole other podcast on that one and how it happened and the whole thing. So now again, we have more communication. There's more blending of different people, of different races, different economic status, different genders. So you have all of this happening. And it did start out as prescription pills. And then they said, okay, we're going to put in a program called iStop. And iStop was a program that you couldn't doctor shop anymore. So in New York State, there was a lot of, I'm going to go to this doctor, and then I'm going to go to this doctor and this doctor, and I'm going to get, let's say, 3 to 4 different, opioid pain medications, but nobody was tracking. So
Mm.
iStop did that. And then when you have areas like where we work in an area of Port Jervis, you have New Jersey and Pennsylvania right on the border. So then they were like, okay, New York did this. We're going to go over to New Jersey, or we're going to go to Pennsylvania. We're going to get it that way. So then it was like, well, now we have to do this across the United States, which they did. And an interesting note for, I don't know if they're still doing this now that recreational cannabis is legal, but in New York State, if you were on medical cannabis program, you were also in that iStop program and they were tracking. I don't know if they're still doing that now. I have to find out. So then that progressed. And we said this years ago in a meeting. We were like, are you prepared as the state for the heroin epidemic that's coming? Because the body doesn't know the difference between a prescription pain pill and heroin. So it's a natural. You're putting iStop, you're making it harder to get these medications, you're upping the price on the streets for these medications because it's harder to get them now. It's going to be a natural. People are going to go to heroin. We were told that's not going to happen. We don't even think that that's going to happen. And then boom, it happened. And we saw it in real time because, as you know, we did the Hudson Valley Interlink Analytic System, HVIAS, which gave us real-time data. So we partnered with an ER in the city of Newburgh at Montefiore St. Luke's, and we partnered with them, and we had real live data happening, and we were accessing it as it was happening. So we saw the switch from prescription pills to heroin as it was happening because we were getting that information, which was crucial because usually in the field of prevention, we're a little behind the trend. Usually just as a field, we're a little bit behind. We were on the trend at that point. But then fentanyl came. And that's a whole other piece. And I don't, I don't understand, if I were a drug dealer, I don't want to kill my customers. You know what I mean? But that's what's happening. And it's in everything. It's even being found on street level cannabis. Not the ones in a legal dispensary, but those that are real street level. It's not often, but it's happening. We're starting to see a little bit more. And when fentanyl hit, it was just like, boom. So we're already dealing with opioids. Now they're getting stronger and stronger, and fentanyl's stronger than morphine. So it doesn't take as much. And the best way to describe the overdose that somebody explained to me and why this particular crisis and epidemic that we're in is different is because the opioids affect what's called the reptilian brain. It was the best way. Mr. Romero from SAMHSA, Substance Abuse Mental Health Services Agency, explained this to me one day, and I just kept it because it was just so easy to explain to people. Blinking, breathing, all of that, that's where it affects. So that's why when you experience that overdose, you stop breathing. That's why, because that's where the overdose is happening in that part of the brain. So it literally becomes like breathing for somebody who's struggling with that addiction. It literally becomes like they can't be. Now, will you die? I mean, I'm sure people have died from withdrawal from opioids, but more people will pass away from an alcohol withdrawal than you will from an opioid. But the discomfort and the pain from it, from an opioid withdrawal is horrible. You feel like you're gonna die. Most people don't though. They get through it. A lot of times they'll need a little bit of assistance, but they'll make it. You are more likely to pass away from an alcohol overdose than an opioid overdose, which people
Right.
don't think about that, right? Because alcohol is legal, so people don't think of it that way. So that was a big piece. So like on the streets right now, you can't really get heroin in our area. It's fentanyl. So that's causing an increase of syringes because fentanyl doesn't last as long in the system as heroin. So they're using more of it. So they're needing more syringes, they're needing more of the drug. And so then you have that piece going on, and then you have that it's getting mixed into everything. I mean, in New York City, they have tests like your cocaine most likely has fentanyl in it. We've
Yeah.
had local overdoses. Someone thought they had cocaine and it was fentanyl, and then they passed away. So there's a lot of this going on. So what we're terming in the field is like fentanyl poisoning, we're wording it now, because it's just in almost everything on street level, which is scary. And now they're coming out with another one, which is not new to the medicinal field, but to the street level. It's called ISO. The real name of it is a long one. I'm just gonna call it ISO, ISO.
I never even heard of it.
It's ISO night. I'm not even going to try to say it. It's a long one. It's called ISO, and it's as powerful as heroin, and I mean as fentanyl. And like fentanyl, it will respond to Narcan, the opioid reversal medication. However, it's going to take multiple doses of it to make it happen, just like fentanyl. Now we also have xylazine on the street level drugs with the fentanyl, which is a tranquilizer. And what that's doing is people will respond to the fentanyl with the Narcan, right? So that would help, but xylazine does not. So now we have a combination going on, then add the ISO into it, and it just keeps going and it's not stopping. And you would think it would be different, but there are literally some who look for the fentanyl now. They want the fentanyl now. They know it could kill them and they're okay with that. So, and that's where we're seeing that in terms of how it's affecting the brain with the addiction and how that's working. I unfortunately, my kids had somebody they grew up with pass away from a fentanyl overdose, and in his early 20s, and he was looking for the fentanyl. That's what he wanted. So it's scary.
It is scary. And when you think of the fact that I don't know if there are people who actually do it, but generally speaking, people don't go to use drugs, substances just because they really want to die.
Right.
You know, it's they don't go and say, I just want to kill myself with therefore,
Mm-hmm.
but it's that addiction.
Yeah.
Someone watching us from Nigeria has asked me to, wrote with respect to the dangers of consuming these substances. I know I think you have already answered this question, but you may want to add to it.
Mm-hmm.
The question is with respect to the dangers of consuming these substances. Are there any positive effects of taking some of them, maybe within the confines of health-related benefits? Do they have health-related benefits that may justify using some of them?
Fentanyl and ISO, I mean, they're really used like end of life. I mean, it's end of life pain management. That is what they're designed for. They're not designed to be taken recreationally. They're really designed to ease the passing of someone who is dying. Unfortunately, we are a society that wants more and more and more, and we want to feel good and we want to have it instantly. And it hit the streets. It's taken its own life on the streets. And what was said to me one day, and I keep to this too. My mentor Martin said to me, we always ask, why do people use? Why do people use? And he goes, we should be asking, why wouldn't they? Why wouldn't they use? If I was in their position, why wouldn't I? What would stop me? Why would I even think that there could be something better if I'm living on the streets and I've lost contact with my family and I have nowhere to go, and why wouldn't you? And so we're starting to really think about it through that lens and said, well, why are you? Well, why wouldn't that person? It's
That is a
really hope.
that is a very, very good question. It's a very powerful thing to bear in mind because I will tell you that, even for someone like me who has never touched any
Hmm.
of the substances, I've never even drunk alcohol, but I had a procedure in the hospital and I was in significant pain.
Hmm.
Just some years ago, I was in the pain was just excruciating. And the doctor prescribed morphine to be
Hmm.
administered. For the first time in my life, they administered that morphine. The pain just disappeared. It was
Hmm.
not like, it was not even like 2 minutes later, the pain went. The pain went, left me right away.
Hmm.
So why wouldn't someone who experiences pain all the time
Yeah.
want to take that for relief, and then
Hmm.
the addiction happens,
Hmm.
right? I will tell you that it scared me. The
Yeah.
way it happened, I got so scared. I didn't know that there was something that could take pain away just right then, that second.
Yeah.
So if you have experienced that, then it becomes easier to
To understand.
understand, right, to understand people who will take prescription drugs, some become addicted to it, and just understand that what they need is help, not judgment.
Right.
And also it helps to put Martin's point in perspective. Like the question should be, why wouldn't they? And in respect to this question that
Hmm.
this person asked from Nigeria, you had also talked also about the use of cannabis for medicinal purposes.
Hmm. Hmm.
And I know that some people who have used it, even if it's just the CBD oil, have
Hmm.
talked about the significant benefits. And one of the things that I've said was over the years, we always talked about marijuana being like, well, of course, a gateway drug, but also just condemned people who would use it.
Hmm.
And suddenly we realized that it had medicinal purposes. And then someone like me says, who knows? Maybe that's what the leaves you actually made for. Maybe that's what the plant was actually made for.
Yeah, and it's interesting that you bring that up because before the night, like around the 1930s, is when they decided to make cannabis illegal. before that, it was used medicinally in America. It could be used medicinally. And then after that, it became like in New York State with a pill, maribinol or cannabinol for cancer patients. That was the only way you could get it, or some sort of life threatening illness like that. So then what ended up happening though is you have a naturally occurring cannabis system in your body, a cannabinoid system, and you have your autoimmune system. What they found was that cannabis actually, when that cannabinoid system is activated, assists the autoimmune disorder system. And so, but then the pharmaceutical companies came in and said, oh, we have these pills now. And so what ended up happening was when you see cannabis becoming illegal for anything medicinal, we'll just keep it through the lens of medicinal, you saw all the other medications from the pharmaceutical companies be introduced. So it was interesting to see that, when you look at the history of it, there always had been some sort of medicinal, but the pharmaceutical companies came in with the money and, said, hey, let's do these instead. And that's what ended up happening. I think eventually it will be in the United States. I think it's a matter of time before they federally, because right now it's still federally criminalized, regardless if it's medicinal or recreational. So it's state by state as to whether they're going to do it. There are people who are finding their way off of opioids using medicinal cannabis. However, there's more research that needs to be done to find that, definitive link between the two. But there's about 20 to 25% right now self-reported people who are involved in those studies right now. I never get in the way of somebody who needs it medicinally. I always feel, even if it's a child and their parents and their doctors are involved, it could be CBD, it could be THC. That is decision between you and your doctor. We talk about stigma, right? We don't want to stigmatize anybody. And it's legal in New York State now. So we also don't want to stigmatize anybody using it recreationally, because we may need them to help us educate about the cannabis, and the laws and the pieces, because there's a lot of misconception in New York State about what can and can't be done when it comes to this. But also we need them because we're still fighting the opioid crisis.
Yeah.
And, and we need all hands on deck, so in our community, we try not to demonize it. We do talk about underage use as we would with alcohol not being okay. In New York State, it's 21 and over. So we do talk about that. Medicinally, we don't touch on that too much. We talk about the differences medicinally, but that's about it. So interestingly, cannabis had been, and then they came out with things called reefer madness and these insane videos and just, stuff that people don't usually do when, they've partaken in cannabis. It's not usually something you would see them do.
Right. I know that
Here.
neither of us wants to get into the politics of all of this,
Mhm.
but I sort of find it interesting sometimes when I realize that the only people who can afford, now that cannabis is legal for medicinal use in a bunch of states, the people who are able to afford the licenses to get a dispensaries and to be able to get that into that business are the same rich people who stigmatized it.
Mhm.
And now it's big business for them.
Yeah, In New York, they've changed the laws. They've let a lot of people out of incarceration, out of the prisons that were there for certain cannabis charges. And they're trying to get them into the business now. And there are people who are trying to come in and they're offering special grants and special loans to try to offset some of that. And interestingly, on the recreational end in the Hudson Valley, we were caught up in a lawsuit from somebody out of New York State who wanted to come in and be part of the recreational business, but you have to be a New York State resident and business to do so. So,
So,
yeah.
so your job is heavy. So how do you take care of yourself as you deal with such massive tasks and as you take care of so many people? How do you take care of yourself?
I vent to Regina a lot. Um, no, I talk to friends a lot, but I like to hike when I'm off. I like to be with my grandkids. So I see them pretty much almost every weekend I have them. I like to be out walking around, being in nature, just breathing in. And sometimes I'll find myself and my coworkers like, don't say this today. I'm like, no, I'm gonna say it. They're like, don't say this. And I was like, but sometimes I'll find myself if I'm here alone and my youngest is working, I actually enjoy just sitting in the silence for a little bit and just really just taking it in, being mindful of where I'm at. And then I'll grab a book and I'll read for a few hours, but in the quiet, like no TV, not even any light. I want the sunlight as my light and just really minimalize everything because there's just so much all the time rushing past you. One day you think you're going to go in and do this, and then a crisis happens, and now, nope, you're not, this gets put aside, and now you're over here, but you got to get that done because the funder wants it. But this is somebody's life. So now you're running over here and you're asking permission to go, can I be late with it? And there's a lot of juggling that goes on. So to have those quiet moments to me is great. And that's why I like to do the hiking. I get my niece or my daughter or some friends and we just go. We find new places around where we live that we haven't been to. And we try to explore and just do new things. Those are the biggest things for me. I appreciate the silence as I've gotten older. I
I
really
know,
do.
many people have watched this and many more will watch it and listen to the podcast. And they have all heard you promise to come to the University of
I'm
Delaware,
gonna come. I'm gonna come.
right?
I'm in.
To speak with my students. And as we say, like when we are not on the screen and people are not watching us in our professional roles, you voluntold
That's
Regina.
okay.
Yes, and so Regina, you actually volunteered Regina to come
I'm gonna get a
with.
text from her later.
And so, and I promise you that you will get a big Delaware welcome.
Oh, that would be fantastic.
It's really a great place to be and to come to, and we'll be looking forward to that. Thank you for
Forward to it.
giving me, for giving us, not just me, one whole hour of your precious time today.
Well,
And
thank
I
you for
really
having me.
thank you, Don. Continue to do all of the great work that you do, and we all continue to benefit from it and learn from you. And
Thank you.
I cannot thank you enough. And so continue to do all of those things that you do to take good care of yourself because we need you to
Thank
be
you.
healthy and safe so that you can continue to be a blessing to us. Thank you very much. We'll
Thank you.
be
I
in touch.
appreciate you. Yes.
All right, Don. Thanks.
Bye bye.